y'all have now reached the end of my technology skills. Anyway, for those of you that don't know me, I think I know most everybody, but I'm Cheryl Arno, and I'm the Executive Director of the Down Syndrome Association of Atlanta. And actually, Bradley is on our board just for minutes left because he is now on the board of the National Down Syndrome Congress. So we thought only being on one board would be best. But I have invited a couple of people like Debbie and Bradley here, and Josh will be getting on shortly. People that have experienced it and gone through the process. And I think Debbie was one of the first in Georgia with Dr. Dedia to get Medicaid to pay for it. And I think that's also a big deal and certainly a big question. I just want to remind everybody that, what's coming up for DSAA is our big buddy walk on October 7th. If you haven't checked that out, we would love to see you. It's like a big old tailgate, and it's just a lot of fun, and it seems to be a reunion for most. But that's what helps fund a lot of our programming throughout the year. And our newest adventure was Camp Brightside, which was a 7-day overnight camp in Rutledge, Georgia. So if you're not a part of our Facebook connections, I would strongly suggest that you do that. And also we have a new Facebook group for children or adults, I should say, that are 18 and older. So please check us out for that, because we want to put a lot of people in there so it can help y'all transition into adulthood. And when you have questions in the middle of the night, like, what doctor would you go to for the Inspire? Here you go. So anyway, without further ado, what we're going to do is we're going to let Dr. Raoul and Dr. Yu speak. Oh, now my dog's going nuts. And then if it's okay, and that's up to y'all really, do you want them to ask questions during when you're talking, or would you prefer for them to let it wait till the end? It's totally up to you.
If it's okay, Dr. Yu, I'll just say, I think if we wait till the end, we'll just kind of go through the basics and kind of get the information that we have to y'all, and then we'd be happy to take questions, whatever you have after we're done.
Fantastic.
Yeah, agreed. And if people want to put maybe is a chat function available, they may want to put it in the chat so they don't forget the question in case they have one early on, and we can scroll through the chat questions.
Well, again, thank y'all enough for being here tonight. And if I can help in any way, please let me know. But without further, who wants to start?
We're gonna speak. Actually, we're gonna alternate, and if you don't mind allowing me to share screen, I'll pull our slides up.
I have to make you the host.
That's fine.
Because we were just talking about that. I don't have the ability. Does anybody know that? It just says make host. I don't know how I can make a co-host. So
that's weird. It should give you both options.
Yeah.
Well, I made you the host, so if you see it, again, I told you my skills are limited. The fact that I was turn on record, I'm so proud.
No problem. Dr. Yu, I think you're the host, so if you want to pull up the slides.
Oh, I'm the host now. Oh, yeah,
you're
okay. Great.
Want me to make her the host?
I can pull the. Is there a way
we both have a copy, so
okay.
Should be fine.
I was like, is it possible for So now we have to figure out the technology. Heat's on us. Can we get? Let me see if I can get you, Nikhil, to also be able to control the screen. So otherwise, I'll have to move the slides for you.
You should be able to do multiple screen shares, and that would let anyone share their screen.
No, Mary, you just wait.
Oh, let's see.
As the host, you can enable multiple screen share. It's down at the bottom where the screen share.
I do see that there, but it's the same set of slides. I think I'll be fine just running, and then Nikhil, you just have me. I'll just try to paste it to your yours. Let's start. So I'm gonna share the screen if I can get this going. Alrighty. Okay. Can you see that?
Okay, yep.
Everyone seeing the slides?
Mm-hmm.
Perfect. Okay, so my name is Jason Yu. I am an assistant professor of otolaryngology at Emory University. I treat adults for sleep apnea with sleep apnea surgery. I did my training back at the University of Pennsylvania up north in Philadelphia for both my general ENT surgery, my sleep medicine fellowship, as well as some additional research years prior to me arriving at Emory. And I've been now at Emory for about 2 years, doing a variety of different surgeries to treat sleep apnea. But you know, kind of the big one that I like to focus on is the hypoglossal nerve stimulation.
And I'm Nikila Raoul. I'm a pediatric otolaryngologist at Children's Healthcare of Atlanta and associate professor of otolaryngology and pediatrics at Emory University School of Medicine. I completed my training at Baylor College of Medicine in Houston and the Massachusetts Eye and Ear Infirmary, as well as a couple of extra years doing research in Boston and getting my Master of Public Health. That is where I became involved with the Inspire device and particularly implantation in this patient population. And I've now been at Emory for 7 years, and we were one of the first 5 centers involved in the initial study to look at safety and efficacy of the device in adolescents with Down syndrome. So we're happy that we've been able to start that program here and keep it going as we've gotten more approval and further studies going.
All right, let's get this thing. There we go.
We both have some disclosures here. Mine are just related to research funding, and I'll let Dr. Yu speak on his.
Yeah, same here. I received some research funding as part of the Georgia Center for Clinical Translational Research on a project where we have been characterizing different physiologic aspects of sleep apnea. But I also have received consulting and research support from a medical device company, or medical device catalyst company called Deerfield Catalyst LLC. So what is obstructive sleep apnea? I'm sure everyone here is familiar with it. It is quite common in the United States and even globally, with estimates almost 1 billion people in the world having it. Basically, you know, it's a breathing disorder that occurs during sleep, where your upper airway just gets so narrow to the point where you're not able to get good airflow and essentially stop breathing or choking. That occurs, and it can occur repeatedly overnight, which results in poor oxygenation of both the heart, the brain, the rest of your body, and can be pretty stressful and hard on the body. So, you know, classic signs that you may see associated with sleep apnea: very, very bad snoring, a choking or gasping type reaction that occurs intermittently throughout the night. As someone who may witness this in a family member or friend, but also if you yourself are considering whether or not you have sleep apnea, you may even wake yourself up with that kind of snorting or choking. But it's true that they're not always symptoms there. You know, at some point choking happens, and when there's an absence of airflow, you'll also have an absence of snoring or choking. And so it's possible that someone's sleep apnea is so bad that actually it's fairly quiet, but it's truly because they're not breathing at all. Some comorbidities that can be associated with untreated OSA, and this is again stress related to just the recurrent choking sensations, the recurrent oxygen deprivation, and the recurrent poor sleep that can take a toll on the body. And so the pediatric side in particular, there's some there's behavioral cognitive deficits that can occur, school failures, poor performance, hypertension, very common in adults. We can see early onset hypertension in kids, which is a bad sign. Poor metabolic activity, including glucose metabolism, diabetes. In adults in particular, risks for stroke, heart attack, having development of pulmonary hypertension, and you can even die from this. There was definitely kind of people who've had known untreated sleep apnea, particularly at night, have an event and pass away. So it can be pretty scary. Did you want to
So
go through this there? Yep.
So obstructive sleep apnea is more common with Down syndrome, as all of you likely know. These children, or these both children and adults, really suffer from midface and mandibular hypoplasia. They have small nasal passages. Their tongue is relatively large compared to the size of their nasal cavity. Their tongue can also fall back. That's that glossoptosis, and that is part of the low muscle tone in conjunction with the relatively large tongue. Their tonsils, their lymphoid tissue, both lingual tonsils and adenoids, can be enlarged. The tonsils that we routinely think of as being in the back of the throat, also known as the palatine tonsils, are typically large and positioned in a way that makes them more likely to cause obstruction. There can be increased secretions, and kids with Down syndrome are higher risk for obesity, and then generalized low muscle tone or hypotonia can contribute to this. Now, this is so much of a common issue that we actually recommend getting a sleep study in all our pediatric patients at 4 years of age, whether or not they present with symptoms. Mainly because there has been some work that's demonstrated that about 60%, up to 60% of patients with Down syndrome who did not present with any symptoms as per parental report actually tested positive for obstructive sleep apnea when a sleep study was done. And so as you can see, in the general population for pediatrics, about 1 to 4%. In adults, it rises to 10 to 25%. But in patients with Down syndrome, that range is significantly higher, at anywhere from 55 to 97%, depending on what study you read. We also know that patients with Down syndrome are more likely to have recurrence of obstructive sleep apnea despite initial surgical therapy. And the definition of obstructive sleep apnea, now this is a very simplified way of looking at obstructive sleep apnea when we look at this parameter called the apnea-hypopnea index, which is I like to describe as a number of times per hour that we slow down or stop breathing. This may affect oxygen levels, oxygen saturation, or it may cause an arousal. But slowing down or stopping breathing is causing some kind of disturbance. Now, in the pediatric population, we have a pretty high bar that we set, because if you get 1 event per hour of slowing down or stopping breathing, you have mild obstructive sleep apnea. So we know that 1 to 5 events per hour is mild, 5 to 10 events per hour is moderate, and then 10 or greater is considered severe.
And on the adult side, that definition is a bit different. Just as a kind of a qualifying statement, the apnea-hypopnea index, even among sleep physicians, is a point of debate, just because the number itself can vary so widely. And although we use it, it's really it's a very rough number. And so on the adult side, you can see that the things are a little bit looser. We tolerate, up to 5 choking events per hour, 1 event every 15 minutes, as being okay. That's completely acceptable and normal. And it may sound a little strange, and some of it is we kind of have to set some sort of bar, and the other is that there's been evidence that even the low numbers, under 10, 5, 6, 7, 8, let alone 1, 2, 3, 4, are really not that bad health-wise. That it seems like people who have the low, normal to mild apnea on the adult side, it's not associated with all those bad things we described: the heart attack, the stroke, the poor sleep. And so on the adult side, anything less than 5 is considered normal, 5 to 15 mild, 15 to 30 severe, and 30 events or greater. 15 to 30 is moderate, and then 30 events or greater are severe. And although this number, like I said, is sort of this rough and tumble number, unfortunately, insurance providers really stick very, very strictly to this. And so kind of no matter how you end up interacting for Inspire, this number ultimately shows up as part of sort of a big gatekeeper of it, because there are specific indications for Inspire.
And the other caveat I'll throw in is when we move from the pediatric to adult population, when you're 17 and you turn 18, you might go from moderate to, or sorry, from mild to normal. You might go from severe to mild. And so those are the other aspects when we're thinking about who can be implanted, who should be implanted, that we definitely consider both from the insurance perspective, but also from a quality of life and comorbidity perspective. So in the pediatric population, surgical treatment is often the first step. And I know it's not easy to see in this picture, but those are some big tonsils back there. And so even in whether it's patients with Down syndrome or without Down syndrome, typically removing the tonsils and adenoids is the first line treatment. Now, we know, again, that patients with trisomy 21 have a higher likelihood of recurrence of sleep apnea after removal of tonsil adenoids, or lack of complete resolution after the tonsils and adenoids are removed. But often, I think what I see in my patients is that they will get better for a period of time, and then we'll see some years later recurrence. And please keep in mind today that we're really talking about one surgical target, but there are a number of other surgical targets that can be causing issues in Down syndrome patients, just like any other patient. We are focusing today on Inspire, but I've seen kids with the same thing, enlarged lingual tonsils, with collapse of the sidewalls of their throat, with floppiness of the cartilages of the voice box, and things like that we would evaluate for any patient who has sleep apnea after removing the tonsils and adenoids. Dr. Do you want to talk about a little bit about your take on CPAP, given that you do both the medical and the surgical side?
Sure. So the CPAP treatment is considered first-line therapy. And for, in terms of kind of the way that it treats and its effectiveness, it absolutely sort of stays on the top of the mountain. It is non-invasive, right? There's really little risk, and it truly is the most effective therapy. The ability to apply extra pressure to the airway to inflate it, almost like inflating a floppy balloon. No matter how heavy your airway, no matter how floppy your airway, that machine can really do it. The trouble with the CPAP is that it's kind of a pain in the butt to wear. For even adults, who they're having a hard time, let alone this patient population where there's truly anatomic and other aspects that can make it very, very difficult. And so it can be very hard to get used to. It can be very hard to get adjusted to. But if you can get used to it and you feel better using it, I absolutely would recommend keep that. And I would not even consider at that point saying, well, we should be doing surgery just to give that a shot. At that point, especially like in my adult population, where I'm not seeing a lot of trisomy 21 per se, but I'll get patients who come in, I've been using my CPAP for 20 years, I love it, it's great, but I don't like taking it on my boat, or I don't like taking it in the RV. It's like, well, I'm not going to put this surgery in your body just so that you have a little bit more convenience on your camping road trip. This seems a little bit unreasonable, especially since you've been doing so well with CPAP. But again, hard to predict who will like it. Estimates are that probably 40% of the population is non-adherent to CPAP. So, a little under half, but that's still a lot. If you think about 1 billion people in the world with sleep apnea, 40%, meaning 400 million people out there, choking away in the middle of the night. So it's still quite a lot of people who could benefit. Did you want to go over the mechanisms here?
Go for it.
Keep going. All right, fantastic. So what is the Inspire? Well, it is a pacemaker for the tongue. Okay, so it's a surgical implant. sort of like a heart pacemaker that you may have, seen in your grandparents or, for a faulty heart rhythm. It's got a battery pack and 2 wires. And the battery pack is surgically placed underneath the skin of the chest, as pictured here. And the 2 wires, one wire stays in the chest and gets inserted between the ribs to measure and monitor breathing. And the other wire gets tunneled underneath the skin up to the chin. And underneath the chin, this wire is surgically placed around the nerve that makes your tongue move, the hypoglossal nerve. And so in all patients who get this device, there are 2 cuts, right? A cut underneath the chin and a cut on the chest. That means 2 scars, right? A scar underneath the chin and a scar on the chest. And this battery pack, it's a metal box, a couple inches wide, maybe a ½ inch thick, depending on how large or how thin your chest is. It may be noticeable after the procedure. There may be a small bump in that area. So if you go to the beach and take off your shirt, it might be noticeable. How it works is at night you turn it on with the remote, and while you breathe, every time you take a breath, the sensor in the ribs feels that breath and sends a signal all the way up to the tongue and makes your tongue stick out of your mouth. And so the whole night, you're just a repetitive tongue sticking out motion, back and forth, back and forth. It doesn't matter whether you're actually choking or not choking. We can never predict when the choking is going to happen. So we just treat all the breaths. So the tongue gets a workout the whole night. And in the morning, you turn it off and you go about your day. And the reason why the reason why we think it works is because the tongue it's just a hunk of meat that's just sitting in the back of your throat. And when you're sleeping and you're more relaxed, that tongue can fall backwards and block the airway. And so if you make the tongue stick out forward, you're, 1, getting part of the tongue out of the way, and 2, you're pulling some of the other structures in the back of the throat more forward to give you the back of your throat more space to breathe. Now, the original study, this is the landmark study published in the New England Journal of Medicine that led to the FDA approval for Inspire in adults, was called the STAR trial. And in this study, they enrolled patients to get the Inspire. And what you can see at 12 months after they got their devices, that at baseline, these were pretty severe sleep apnea patients. On average, they had a AHI of 32. Remember, above 30 is considered severe. At 12 months in this initial trial study, they got them down to about 15 on average. And so wasn't super fantastic. They got them from severe on average to moderate, but there were some growing pains with getting kind of more acquainted with the device and its potential. And so I think that although this was a good first try and very reasonable, there was improvement that occurred later on. What you can see also is that more importantly than that number going down is that people felt better. They reported better patient quality of life scores, less sleepiness, and their oxygen improved over on average as well. So that, knowing that oxygen is a big deal, low oxygen is bad, very, very positive results. Now, over the years, we got better at implanting the devices, got better at managing them. And so, over the 3-year period between 2016 2018, they opened up this registry of patients aftermarket, and they got 100, up to 500 people enrolled who got the Inspire and just were followed to see how they did. And what you can see here is that again, this population, very bad sleep apnea, severe, but in this population they got down to mild on average, which is very good. So down here, at 10, I think that's a pretty darn good result. And what we're seeing in terms of the health literature is that the mild apneas are really not that bad. And so even if you get someone from severe to mild, I think that's a pretty darn good target, especially if the person doesn't have anything else, is not using CPAP and otherwise would just be sleeping and snoring away in the middle of the night. And so at 12 months, at both the initial titration and at 12 months, you can see that it stayed robust. The settings were robust. 94% of people got into the mild category, 80% got less than 10, and then about half ultimately got cured. And so again, curing the sleep apnea with Inspire is a high bar. We can't really make a very strong claim. It's obviously possible. You can see it happen in more than slightly over half, but there's some reasonable expectations here that it's probably not going to completely remove all the choking events, but it's going to significantly reduce the amount, especially if you've got really bad sleep apnea. The other thing is, adherence. So do people use it? And they absolutely do. This data average 6.5 hours per night. Is almost essentially the average spectrum of what people get for sleep. They sleep the whole night with it. And every patient of mine essentially says the same thing. They use it the whole night. Some people sleep more, some people sleep less, but it's not because of the device. Whereas for CPAP, in general, people talk about average usages of 4 hours a night. And, people aren't sleeping the whole night with it. They're ripping the mask off, they're trying and they give up. And so one of the strengths of this is, even though it may be slightly less effective than CPAP, you're using it for the whole 8 hours. Whereas if you're having CPAP only half the night, and the other half of the night you're snoring away because you don't like the CPAP, which therapy is actually better? And I think that those are the kind of unclear questions about the utility of CPAP and people who use it. The other thing is, on follow-up, was patient satisfaction scores. And so they gave a survey out about the Inspire and their experiences. And what you can see is some of these questions are a bit loaded, but suggest that people really do like the device. They're very happy with it. I mean, it's a surgery. It's a 3-hour surgery. People get cuts. They have to heal from it. They got to get used to the device. I talk to my patients. It's a journey, all right? This isn't something that just happens overnight. You don't just get a CPAP machine, put it on, and then there you go. That's it. No, the device takes a while to be placed, healed, activated, get used to. And despite all that, you can see, high 90s in terms of satisfaction, decision to do it again, recommending it to others. So people have a very positive experience with it overall. All right, switch over to the downside now. Oh, Nikhil, I think you're muted.
I apologize. Thank you. As I stated before, we were one of 5 centers you can see listed down here who participated in the initial trial looking at safety and efficacy in patients with Down syndrome and obstructive sleep apnea. And the reason that we chose, we thought that this was a viable option for treatment for this particular population is because we know the tongue is often a major issue. As we talked about before, the tongue is relatively large for the size of the mouth and then does tend to fall back. And so in this multi-institutional trial, you can go ahead, next one.
Okay.
In this multi-institutional trial, we looked at children and adolescents aged 10 to 21 with severe obstructive sleep apnea, anywhere between an AHI between 10 and 50 events per hour. And I should say specifically that we were really focused on making sure that most of their issues at night were obstructive events and not what we call central events, which are, wouldn't be treated with this. And then they had to have a reasonable body mass index, less than the 95th percentile on neurotypical curve, so not the Downs curve. They had obstructive sleep apnea despite having their tonsils and adenoids out and were not able to tolerate CPAP, or they had a tracheostomy. The first patient actually who underwent this up in Boston actually did have a tracheostomy and was able to be decannulated following implantation. We needed to see on sleep endoscopy, you can see it's drug-induced sleep endoscopy, or DICE, as you might hear, that we didn't see that the entire airway was collapsing like this up high in the back of the nose, kind of transitioning to the back of the mouth. We really wanted to see that the tongue was falling back, and then potentially even if the palate was falling back, those can typically respond to the tongue coming forward. So quickly, essentially in that study, we chose patients who met the criteria. They got a DICE. We had the DICE reviewed by people who were experienced in implantation on the adult side. And then if they agreed, then the patients underwent implantation. They spent a night in the hospital and then they went home. They were activated, meaning the device was turned on at 1 month. And in our trial, we actually had a sleep study the same night to make sure that patients could tolerate the device at the level that was set for them. Then at 2 months, we would repeat the sleep study, but adjust the device to see if we could minimize the number of apneas and hypopneas occurring. And then we did it again at 6 months and then at 12 months on the final setting. And what we were really looking for was the change in the AHI from baseline to 12 months. And typically in sleep surgery, we consider 50% decrease in AHI as surgical success. And so that we use that benchmark as the standard. The other measures we looked at were the time spent with an oxygen saturation of less than 90%, as well as a time with high carbon dioxide levels, because if your airway is not open, then you're not breathing out the gas either that you're supposed to be getting rid of, which is carbon dioxide. So those levels can rise. And then we also looked at quality of life scores using these validated questionnaires. We found that we had the first 42 patients is who we published, and COVID did end up causing us to halt our enrollment early, but we had very promising data that suggested that the device was safe and effective. One thing I will note is in this patient population, we didn't have much diversity, and it's not listed here, but I believe all of our patients, or the vast majority, were Caucasian. And this was related to this access, knowledge, and then coverage with regards to insurance, and as well as the cities that we were enrolling in. So that certainly affected the initial patient population, but we had, the first 42, we had a good age range as well as distribution between males and females. So we found that the implant was safe. As you can, I won't read through all of the adverse events, but at least in these patients, we didn't have to, 2 patients needed reoperation, and that was one for issues with the way that the connection of this wire that comes from here went into the battery portion. And then another, I believe, was for improper positioning of the lead. But generally speaking, the device in the surgery itself appeared to be safe. And then we found that the device was also effective. You can see that on average, the patients went from severe obstructive sleep apnea to moderate. And these are, this is the whole cohort. I will say that when I look at our own patients who were enrolled in this trial, all of them went down to mild or just barely moderate. So with appropriate selection, we do think that we get better at picking the right candidates, just as Dr. Yu said for the adult population. We also found that the amount of time that the oxygen was low was decreased, as well as the amount of time that the carbon dioxide was high went down. And then on the next slide, I believe we'll look at, I guess we didn't talk about efficacy here. So on average, we saw 12.9 points decrease in the AHI. If you look at that 50% decrease in AHI, the 12-month response rate was at 66%, and 73% of patients had an AHI under 10. So we took them out of the severe range. Again, as Dr. Yu said, the nightly usage was excellent. So if you're comparing to CPAP and you're looking at, is it worth it to have 4 hours of treatment where you have no obstructive sleep apnea, or 9 hours where you have mild to moderate? One would probably argue that it's better to have it pretty well treated the whole time, as opposed to mostly, at least half the night spent in a really severe state. Quickly, quality of life also improved in a modest fashion per caregivers. And I think this has led us to change how we counsel families, because there are other sleep disturbances that can affect quality of life. We know in our kids with Down syndrome, there are other health issues that can affect quality of life, whether we're talking about thyroid disease or celiac disease or things like that. So I think that's something that if you're going into this, you're thinking about this as an option for your child or for yourself, to just keep that in mind, that there may be other things that can impact quality of life. And so we know that 73% reduction in AHI of less than 10, so taking that as severe, is good, but can we be better? And as Dr. Yu said, should AHI really be the primary outcome? Are there other metrics we should be looking at? And so we've actually embarked on a second trial. You can go to the next slide. Okay, so what we've seen is, and this is based on the fact that there are data that show that obstructive sleep apnea syndrome is it does affect neurocognition, our patients with Down syndrome. And so that led us to then look, particularly they looked in Boston before we started this trial, at a subset of patients. And anecdotally, 16 out of the caregivers in the first group of patients who were implanted up in Boston reported subjectively that they noticed cognitive improvement. And then 14 of 16 reported improvement in speech. Now, we don't know exactly why, but we think that it may be a combination of better sleep, so that their speech is clearer and they're less foggy, but also that tongue is getting a workout. So maybe there is some strengthening happening that is improving speech. And so in the last 6 children implanted at Mass Eye and Ear in Boston, they actually did perform pre and post neurocognitive and expressive language testing. And then they found that it looked like overall there was improvement between the baseline and follow-up scores in many categories. And so mean change in the total number of utterances went up by 12.3 points. And so we now embarked on a multi-center trial, which I believe we're up to 8 centers now, and we are one of them, looking at the effects of upper airway stimulation on cognition and language in kids with Down syndrome, or I should say adolescents, 10 to 21-year-olds still. And so this, coupled with the fact that we have FDA approval that was obtained in March for patients, it's actually 13 and older with Down syndrome, 13 to 18 with Down syndrome, has made the device in appropriately selected candidates much more accessible, because now Medicaid, we've gotten Medicaid approval, as well as the ability to implant on this trial. So if you have a patient I should say, if you are a caregiver who has a child, or you yourself are interested in the device or in the trial, you can contact me or my partner, Dr. Clarice Brown. Unfortunately, I'll be out of the country for some time on doing some research internationally. But when I'll be returning next year, and we'll be back doing the implantation. In the meantime, Dr. Brown will be doing this along with Dr. Yu. And so if you are interested in that trial, it's similar to the prior trial, except that baseline neurocognitive testing and expressive language testing is obtained at before implantation, and then at 6 months afterwards. That's the only added component to this part of the trial. And so, as I said before, it really takes a multidisciplinary team to investigate something like this and get it off the ground, especially for patients who are vulnerable and have other things that could be affecting their health. And these are the list of all the people who have been involved in the study of upper airway stimulation for children with obstructive sleep apnea and Down syndrome, and has allowed us to move forward with getting FDA approval and making the device accessible to more families. So with that, here's how you can contact us, and we're happy to take any questions now.
Great. I'm going to exit out the slides now, and we can. Looks like we've got some chats here. Okay, so there's one chat question. My daughter is diagnosed 3 years ago with mild to moderate sleep apnea. Currently does great with her CPAP, but at age 33, I can't see this continuing over the long term. Not to mention she has eczema of the face and tends to get extreme irritation. Will she qualify for Inspire? So just to clarify on that question, she is 33 years old. Is that whoever asked that question, feel free to just type in yes or no if you don't want to answer verbally. was it, I think, is it Rita? I see you trying to talk, but I don't think either the mic's not working or we can't hear you.
Are you able to hear me?
Yes, yes.
Sorry, I had to turn in my hearing aids to get them updated because they weren't working and I couldn't hear you all without the headset. She is 33.
Okay, yeah. So for trisomy 21 patients who are over the age of 18, they're really, you sort of fall into the adult criterion. So it's FDA approved. It's not really experimental in that standpoint. The only things that we need to discuss are, realistic expectations with regards to the anatomy, and that maybe it's going to be a little bit more difficult than the typical adult coming through. But there's really no reason that she couldn't go through the evaluation. Now, on the adult side, the criterion that are required are moderate to severe sleep apnea on the adult numbers. So it has to be an AHI greater than 15. And so if she has a mild moderate, and the last time she had a sleep study was, at a young age, and it was a pediatric sleep study, then those numbers
it
would
was
be
an
no
adult
good.
sleep study.
Adult sleep study. Okay.
Mhm.
If she's moderate, greater than 15, then yes, she can definitely get considered for Inspire. Her BMI at the moment has to be below 40.
It
That's
is.
the new FDA criterion. So she can't be, she can't be overly obese, and she needs to have moderate sleep apnea or severe sleep apnea. And we still have to do this DICE procedure that Dr. Rao mentioned, where we look at the pattern of the choking and want to make sure that the tongue is part of that problem and that there isn't too much neck choking.
Okay.
Too much neck choking would put you would be a contraindication to getting the device.
Okay. All right.
Yeah.
And I'll just piggyback on that. And Doctor, you talked about the BMI requirement, and answer Debbie's question here is that that's correct. I mean, it's a from a trial perspective, it is still a requirement, but because we have FDA approval at 13 and up, then we go by the BMI criteria that Dr. Yu mentioned. One thing I think to keep in mind is that, when we talk realistically about how weight impacts the effectiveness of the device, it is probably a little less predictable when as BMI gets higher. And I can say, I have at least one patient who, at the time of implantation, BMI was a little bit lower. And then once there was weight gain, the sleep apnea was still much improved compared to the preoperative status, but was not as good as when we initially had implanted the device because of that weight gain. So definitely something to consider. Even though we have a higher benchmark now, we consider patients who are at higher BMIs. It would just be something to talk about with your surgeon.
Yeah, I
go
would
ahead.
also add that concur with the BMI. Just because they say it's okay to implant in a higher BMI doesn't mean it's going to work in a higher BMI, right? And then on top of that, just because they say it's approved for BMI of 40 doesn't mean your insurance is going to approve it for a BMI of 40. Many insurances have a blanket policy as an adult where if you're under BMI of 35 or under BMI of 32, it's completely approved. Otherwise, it's denied without question. And for those situations, typically the only thing I could do is tell the patient to lose some weight and come back. And I'm not asking them to become lean or thin. I'm asking them to lose, sometimes it's a matter of 10, 15 pounds to get that number below their insurance threshold. And it makes it a heck of a lot easier for us to get it through. The other part of the question, I guess, that I forgot to answer was the idea that, she is using the CPAP, but you don't feel like it's a long-term solution. Now that's a decision that you and your family and the patient have to discuss and decide. I don't make that decision for you guys. So if you feel that that is true and we discuss it and I give you the options, I give you the risks, I give you the benefits, and you decide, you know what, it's still worth it. I have no problem moving forward with that scenario. It's just, for me, I don't feel like it's my place to judge for you whether or not you feel like CPAP is good or bad for you.
Well, I think it's a matter of, as long as I'm around and telling her to put it on and helping her put it on, she puts the CPAP on. But when I'm no longer here, who's going to put that CPAP on her?
Yeah,
Put it
yeah.
on correctly.
I have had similar, so I've had this device placed in like patients who've got Parkinson's or whose family members have Parkinson's, and the conversations, same thing. This person's got Parkinson's. He's slowly having a lot of physical disability. He can't strap that mask on himself, and the wife or the spouse is getting older, and I can't do this for them either, and in the meantime, they're forgetting to put the CPAP on. He's snoring away in the middle of the night. I totally see that as a reason. It's a legitimate reason. There's a difference between that and the guy who, is perfectly fine with it and just wants to bring it to his campgrounds, just every once in a while, so he doesn't have to have a machine around. There's distinctions here with the risks and the benefits.
Mm-hmm. Okay.
And then Mr. Kiefer, your question for the trial, they have to be actually the trial is at 10 to 21. But the FDA approval is 13 and up. So we can implant as young as 10. Now the caveat is that if in this current version of the trial, if they are not able to complete neurocognitive testing, then they aren't eligible for the trial because the endpoint being different. So it's something that we've complained about a lot because we've taken some of our younger patients out. But with the FDA approval, we're still able to offer it to more patients than we were able to before.
Can I just jump in before you go to the next person? Because I want to circle back around to the BMI, because rumor on the street was BMI has been lifted. So clearly BMI has been raised, but not necessarily lifted.
No, BMI is not, and I will be honest in my kind of opinion about obstructive sleep apnea and the contributions that the higher the BMI, it's been shown that the higher the BMI, the less likely the device is going to work. There is going to be a theoretical threshold where, at some BMI, it's really basically no one would receive benefit. Now, I don't think that that's a BMI of 40. I'm just giving you, it's a theoretical limit, but, I would be wary implanting, BMI, for sure, BMI 50 or plus in this adult population. There's a lot of risk for surgery in heavier patients too. It's the heavier, the larger you are. It's not simply just whether the device is going to work. There are other health problems that start to prop up, other risks, and just the risk of the surgery. And when you add all those things together, the fact that the surgery becomes riskier and the benefit becomes less, why are we doing this, right? So it will never be lifted completely, okay? And I think that it's the wrong way of looking at it, okay? And just because the BMI is going up, you may, again, it's this assumption, oh, well, that means that it's going to work in this population. It's like, no, that's the wrong way of looking at it. We have to look at each patient individually and say to ourselves, with the best information that we have right now, is this option worth a try? Because it's not going to work in everyone. It really, I mean, even in the best data sets, we can see that a lot of people on average get some benefit, but not complete benefit. And in that pile is definitely plenty of people who, it's a paperweight, right? They got it in, they went through the surgery, the healing, all this stuff, and it has not helped them a lick. So, it's the surgery is not a guarantee. It's not, and so I don't want people to come thinking that somehow, oh, I qualify for Inspire, it's going to be magical, it's going to be this or that. I get adult patients who come in all the time because those commercials on TV are really, really, really terrible and uninformative, and they think that it's this magical thing that's better than sliced bread, and I have to give them a little bit of realistic knowledge on it.
Dr. Yu, and I'll add, y'all spoke about different avenues and stuff. About 3 to 4 months after Bradley had the Inspire implanted, Dr. Dadia took him back in and removed some tissue in the back of his throat to open up his airway even more. I just looked because I thought maybe I had not remembered it correctly. In 2018, Bradley's AHI was 105. And when the Inspire device was turned on, our next check, I think he was around 32. When they removed the tissue in the back of the throat, it brought him down to in the 20s. And I think he's been hovering between 18 and 22, 23 the last couple of years. So, I mean, that's how big of a huge difference it made for him. As far as the surgery and the recovery, yes, there was that recovery time that we had to work through and get through for about a month until they turned the device on, and then getting him used to the sensation of the device, which is still one of the things we battle if we try to up the voltage on it. But just wanted people to have a parameter of how severe and where it brought him to, in a few years, and what a difference it makes in everything.
So the next chat question, I guess, was just directed at me. So I do see patients and operate out of Emory Midtown. That's where I do see patients. I am scheduled out a few weeks at the moment. If you're trying to get an appointment with me for Inspire in particular, it would be helpful if you or your family member, whoever you're bringing to the clinic, has a copy of an old sleep study that we can have to review. That would be the most ideal. If the sleep study is really old and you really can't get a copy of it, that's okay. We'll probably just get a new one. But if it's within the past 2 years, definitely it makes our lives a lot easier if you could bring it in, because it could be used for our evaluation without you needing to get a new sleep study.
There are a couple of hands up.
Oh, sorry. I guess how do I get Christy? I see Christy Hernandez.
Yes, I'm Carlos Hernandez. Chris and I are here listening. Our son is Elijah. He's 20 years old. He had a sleep study done when he was around 7. And he got his adenoids and tonsils taken out. But we were one of those where after that was taken out, we never had another study again. And we're just now seeing, well, this last year, he falls asleep. As soon as he gets still just a little bit, he falls asleep. He's always falling asleep. So we're suspecting that that's what's going on with him now. Would you suggest that we go through you guys to get a sleep study, or just a sleep study from anywhere?
So so he's an adult now, and
He's an adult, yeah.
If he hasn't seen anyone in quite a while, my recommendation would be for him to go see the Emory Sleep Medicine Center. So I see patients who have gotten the workup and who've tried the CPAP. Because remember, I said kind of CPAP is sort of that kind of top of the mountain treatment. If you haven't tried CPAP, it becomes a significant barrier on the insurance route. They want to really see that you've given it a try, that you physically put that thing on you. Now, there are obviously certain extenuating circumstances that may prevent you from actually putting on a mask, perhaps some sort of deformity or something like that. And the insurance company obviously it'll make sense. But they really, before they'll let you do surgery, they want to do a CPAP. And I don't do the CPAPs myself. The sleep center does. They also are the ones who control and organize the sleep studies. I can order them, and Dr. Rao can order them, but the sleep center and the sleep doctors are who execute it. And so if your child is needing, it's been a long time, needs a new evaluation and potentially a CPAP trial, go through sleep medicine at Emory. Okay. And then at that point, if the CPAP is really a no-go, which in all likelihood is a possibility, happy to have that guys come back and see me, and the sleep study will be in Emory's records, so I'll be able to see it very easily, and it'll just be a smoother transition.
Dr. Yu, can you quickly comment on for Mr. and Mrs. Hernandez, a home sleep test as an option?
For adults, a home sleep test is an option. It's in fact the most common option at this point for us. For on the adult side, it's just from the insurance side, it's cheaper. from our side, it's faster. People like it more, and since COVID, we've gotten kind of, I guess, more streamlined to be able to offer that. Now, on occasion, if the home sleep apnea test is got poor data quality or it's difficult for the patient to use for some reason, we can then use that as grounds to get an in-lab study. It would just sort of extend the workup, but home sleep apnea tests are absolutely fine.
And I'll tell you,
Okay.
on the pediatric side, that's not the case. They aren't validated, so we do require in lab. But if we get a poor study, then we can talk on a case by case basis about where to go next, because sometimes the sleep studies are not representative of what's happening at home. So we always start with that home in labs test, and then we can go from there.
And I was also just recently, he's been seeing a dermatologist, and they gave him, what was that medication? Kind of like a Benadryl type thing. And I was kind of concerned with the Benadryl at night, and that he may have sleep apnea. Do you see that as a problem?
Not from Benadryl, no.
Okay. Because I didn't, I was, you get online and you read all kind of crazy stuff. It says it may just relax the tongue too much and make it a little worse. So that's what I was concerned about.
If the concern is, lifestyle things, if the concern is really that these things are what is making the sleep apnea happen or not happen, it would likely suggest that the sleep apnea is so mild and not that bad anyway. If there's anything substantial, if you've got moderate to severe sleep apnea, yeah, certain things might make it better, certain things might make it worse. Even, the humidity outside, or, how much salt you had for dinner. Yeah, maybe all that, contributes, but then you're starting to really get nitpicky about it. Right. So kind of broad strokes, if you're worried about having sleep apnea, he probably has bad enough sleep apnea that these little things are not really making that much of a dent.
Okay. All right. Thank you so much.
Mary?
Thank you. I just want to clarify again the threshold for insurance related to having first attempted use of the CPAP, because I heard you saying in the end you're not going to make a judgment call for a family about the effectiveness of ongoing CPAP treatment. Does insurance require demonstration that CPAP therapy has failed or cannot be tolerated before insurance?
So at the moment, how I've seen this play out is if we have a discussion in the office and I document the reasons why we feel that CPAP is not oh wow, my hand went up. It's like AI or something. I totally see a future, a dystopian future, where these insurance companies are going to be like, there are too many Inspires being implanted. It is way too expensive. We got to find a way to cut down on this. Oh, we need to show that you absolutely are not using CPAP every night and doing this and that. That's what, I can see that being a situation in the future. It would be terrible. It's not that situation right now. They sort of go by what we say. And so we document that, yeah, you're using it every night, but it's a struggle. The patient's really not getting much benefit, claustrophobic, whatever, the thing is. And the caretaker, I think on the pediatric side also, and on the adult side in disabled patients who I've dealt with sleep apnea, and the patient side too, the parent has to wake up 5 times a night to put the mask back on the patient. The patient fights the parent to put on the mask to the point where they're exhausted. Maybe they're even prone to injury. These are all things that absolutely you document that it makes sense. They'll accept that, I think, at the moment. It would be sort of cruel not to. And it sure is easier to push a button on the chest than to strap this thing on somebody's face.
So our situation is my daughter has been diagnosed with OSA, and the initial line of treatment was CPAP, and it was effective in terms of the results. However, what you're naming in terms of the dependence on me as caregiver to operate and get up in the night, just like you said, if it come off, if she has to use the restroom, and she was just not able to manage the device. We moved her onto an oral appliance,
Yep.
which the tests follow-up sleep study did indicate was giving her effective treatment. However, most recent sleep studies showing it's not treating effectively or as effectively as it had been. So we are considering next options. Do you think we need to go back to CPAP and then come to you for a consult, or can we?
No.
Are you a next step in
No,
consult?
once you've tried it once, that's enough at this point. Yeah, I mean, you're welcome to try it again. You're welcome.
No,
It's always an option.
No.
I always bring that up as an option.
Yeah.
We discuss different treatments and we say, listen, you don't like what I'm selling here. CPAP is always an option. It's a safe option. It's an effective option. It's just a pain in the butt option. And if you are, it depends. And in the end, we still have to do an evaluation. Just because you come and say you want Inspire doesn't mean you get one, right? We have to make sure that the sleep apnea is severe enough. We got to make sure that your collapse pattern is amenable for the treatment. And so
we have
go through that
determined
workup
that.
and still go back to CPAP, because I say, I'm sorry, you've got a lot of neck choking. You're not a candidate. You don't meet the criterion for Inspire. It's not, just because you come through the door and see me, unfortunately, is not a guarantee that the surgery would be a fit for you.
She's a patient was a patient at Cincinnati Children's during her first diagnosis with Sally Schott. So we know she's a candidate, but we wanted to test this oral device as the least invasive option. And again, we've gotten a number of good years of treatment, and we haven't necessarily definitively said it's not, but right now anyway, we have a repeat study coming to reassess. So
that's and that is absolutely, that trajectory just makes sense to me. And it's a trajectory that even on my kind of adult kind of routine sleep apnea patients, if they haven't tried an oral appliance and they don't have any dental problems that would prevent them from trying it, I have one in my pocket. I show them and I tell them, hey, listen, this or that. And if I was you and I had sleep apnea and an oral appliance could work for me rather than having a surgery and putting this device in me, I would take the oral appliance any day of the week.
Right.
And so a lot of my patients come through and I don't fit the oral appliance. I don't make any money off of the oral appliance, but I send them home because it's the right thing to do. Because so I agree with you that the oral appliance was a good first step. If it's not working anymore, that is what it is, and we've got to consider other options now.
Okay. All right. Thank you for your time.
Any other questions?
Dr. Yu, I wanted to ask, I don't know, you talk about the insurance, whereas with a lot of our adults with Down syndrome have Medicaid.
Yeah.
And I know when Bradley went through this process, it required Dr. Dadia to have at least 2 years of data of not being successful with the CPAP and a lot of other issues there before we could even submit it to Medicaid. And we submitted it 3 times before it was approved. And literally the day it was approved, he had him scheduled for surgery the next day because he was afraid they would change their mind. So I don't know if Medicaid is still being that restrictive with it now or not.
Yeah, it's a good question. I am fortunate to be young enough not to have gone through much of the tumultuous first couple of years where these things were getting approved and denied. They were going to pay for it and then they took it back. Like when I was in training for a whole year, my institution stopped Inspire implants because they implanted several and then the insurance companies actually asked for the money back, which is crazy. So at the moment, I've implanted a few Medicaid patients and they do require a letter of medical necessity that I have to write. So I just write a letter, and then at the moment, I haven't had any rejections from the letter, but I also haven't written that many letters. So, but none of the letters required what you just described, 2 years of non-compliant, blah, blah, blah. No, it was just a very straightforward, this is why Dr. You think this person needs it, and it has been fine.
Well, good. I'm glad that it's not that far.
Yeah, I'm sorry. I was just going to piggyback on that since the FDA approval came through for 13 and up with trisomy 21, that has absolutely helped our process on the pediatric side of getting approval from Medicaid. We don't have, it's within a few months we'll usually get an approval.
but Medicare pays for it. Like my daughter's got Medicare and Medicaid.
So if you
So,
got Medicare or Medicaid, Medicare covers it also completely.
okay.
So I mean, I don't know the nuances of the Medicaid plans in terms of, you know, when we say it's covered, it's covered. I don't know if there's a copay or deductible or something that you guys have to be on the hook for with the Medicaid plans. I really have no experience with that, but I can tell you that at least from our side, having submitted to the insurance and getting that approval, saying that yes, they will cover the surgery for that patient. You know, that's kind of what I see on our side, which is yes, we're able to book it, and you're not going to get footed with the whole bill. You know, otherwise, I don't know what the nuances of whatever pay structure there is for Medicaid.
Well, if there are no other questions, I can't thank Dr. Owell and Dr. Yu enough. I learned so much, and I think this was a really important. People are talking about it all the time. I live with it. Bradley is a great example, and he is so compliant, and it's so easy, and takes his little remote and turns it on. It's pretty extraordinary to watch. And I think that, you know, as I don't have to tell y'all, within our world, the CPAP is very hard for the caregivers and the individuals that we're working with. So to find other options, I think, is a big thing for our community and as a whole.
I think that Cheryl, just again to reiterate that, because it seems like it's a sentiment that that people bring up and want to know, is that sort of, it almost feels like, well, is it guilty for me to want to put this in because it's hard to manage, and I don't think that's I think it's a very legitimate reason, quite honestly. It's a quality of life for the family. It's a quality, I mean, it's quality of life for the patient too. Just, I mean, if you're having to put it on multiple times a night, that just means that the patient, that, you know, they're not sleeping the whole night either. So,
Right.
so you know, if you can get them to sleep the whole night, you know, without any disruption, with the device that's tolerated, and you get better sleep, you know, patient gets better sleep, it's a no-brainer. So I think you bring up a good point, and it's one that I've seen kind of individually, never kind of thought about kind of more systemically, but yeah, absolutely. Caregiver kind of reliability can be a reason for a therapy that's just easier for everyone to take care of.
Yes. Oh, that I can't think of a better way to end this evening. We will be sending out the video to anybody who signed up for this, so y'all will all receive it, but then it will live on our website. If you want to send anybody to it, so y'all can get more information. But thank you again for coming out.
Thank you all very much.
The thunderstorm
problem.
has gone
Thank you.
away, and Dr. Owell, we wish you safe travels.
Thank you so much.
Take care.
Yeah. Have a good night.